as the infantile cholestasis, because we lot of time discuss neonatal cholestasis, we discuss approach to jaundice in OPD practice, we discuss approach to chronic liver disease in the older children, but we always don't pay attention to the infantile cholestasis. Unfortunately, my talk will be in terms of definition, etiology, clinical presentation, and clues in history and physical examination. So there is no definition of infantile cholestasis. So anything beyond 2 to 3 months till 1 year of age, having a direct jaundice of more than 20%, which we extrapolate from the neonatal cholestasis definition, and that is what I meant to say the infantile cholestasis. But what is the difference? The difference is in the presentation. You will come to know in couple of minutes why it is different than the neonatal cholestasis, the etiological causes, and what we prefer. Means we were discussing in the morning that how we have to cut down on the cost and the number of tests to get the pinpoint diagnosis of these cases, and what are the treatable options in them. So we all know there is a cholestatic disorder. So when I speak about infantile cholestasis, so if I have to investigate these children, I have to know that what is the etiology. So there is one is the canalicular defect, what we call as a BSEP defect or FIC1 defect, or you have the MDR3 defect. There are new things which are coming up is the TJP protein defect, then MYO5B defect, or you have the FOXR ligand or inhibitor. So one is the canalicular defect, and which we used to call as a PFIC. So progressive familial intrahepatic cholestasis. The other is the lipid metabolism defect like Wolman disease or lipoprotein lipase deficiencies or hypertriglyceridemias. The third group is the paucity of interlobular bile duct like Alagille syndrome or non-syndromic, and metabolism disorders like urea cycle defect, mitochondrial, or the Dubin-Johnson or Rotar syndrome. So what is the percentage of these disorders? So when we talked about neonatal cholestasis, can anybody remember the percentage? How many will be the biliary atresia in neonatal cholestasis? So 1 in 3 is the biliary atresia. So 35% is biliary atresia and 35% is your PFIC group. But when we talk about infantile cholestasis disorder, 60 to 70% will be the canalicular defect. So our whole energy should be going to diagnosing this canalicular defect and the paucity of interlobular bile defect. The metabolism disorders, lipid disorders, or any tyrosinemia or any other disease is almost 10%. So when we are investigating neonatal cholestasis, we don't order torch test because we know that it is less than 5% of the etiology of the neonatal cholestasis. Similarly, in infantile cholestasis, we don't order a direct metabolism test like urine GCMS or TMS, succinylcholine or blood TMS. So these are the tests which are the fancy names. We don't order. What we order, we will come to know. So let's go with the case. This is a 3-month-old boy having a jaundice and failure to thrive. So at 3 months, this child is 3.7 kg and having hepatosplenomegaly. So this is the true case where the first child died at birth, and this is the second child which is having this hepatosplenomegaly. So we did the test. So these are the tests done in the 2021 which showed a PT-INR of 1.26, 1.15 and 1.5 and GGT of 147 and 277, and there is a direct jaundice. 7.8 is the total and 5.5 is the direct fraction. And SGOT, SGPTs are mildly deranged. So what we are looking at is a disease which is the GGT which is high and a PT-INR which is deranged, but at the same time the child is having a severe failure to thrive. The other tests were done, GALT enzyme, the liver biopsy suggestive of cholestasis, ultrasound showed some raised cortical echogenicity, and this was the child. So can anybody comment on this child? At least he looks syndromic. That we can see that this is a flat facies. Okay? And look at the mother, the same features. And and then this is the bulbous nose, and slowly, slowly, like mother, he will have a triangular faces. Okay. So this case, what will be the next investigation? So nowadays everything is genetic, like what we discuss in the hematology panel discussion and the lecture by Dr. Shraddha, that we always rely on the NGS or clinical exon sequence or whole exon sequence. And this child underwent whole exon. This child is from the Latur, and I took all the cases which were present from the Latur. So what we got is the chromosome 20 JAG gene defect, a classical case of Alagille syndrome. So what we taught as a Alagille syndrome, we should have a heart, you should have a vertebra, you should have renal. So it is not something which is there in all the cases. And what is the cost of NGS or clinical exon or whole exon nowadays is 10 to 15,000, depending on now we are doing the study, so we are doing it at 10,000 rupees per case. So in infantile cholestasis, the major cause is either a canalicular defect or a paucity of interlocular bile decay, and this child is diagnosed as Alagille. Treatment is same, vitamin A, D, E, K, and what will happen to the Alagille syndrome is they will have a severe itching after 6 to 7 months of age. So what we start for the itching, and it is very important to know what are the drug options we have. Ursodeoxycholic acid 30 milligram per kg per day divided into 3 doses. Rifampicin 10 mg per kg per day, OD or BD depending on the severity. Ondansetron, simple MSET or Ondem, is the drug of choice for the itching. So we should be giving this drug for a longer duration. Oral cholestyramine, which comes in the sachet, and rarely we require opioids, and very, very rarely when the child is not having a relief with the medicine, then the liver transplant is the option. And these are the children, in spite of the liver transplant, they will not gain weight. So this is a syndromic form which present with failure to thrive. So once you correct vitamin deficiencies, you correct the type 1 nutrients, and you give the MCT based diet, probably these children will start growing at their own potential, not as a normal children. So the failure to thrive should not be a criteria for a transplant. Like in any liver disease, we take a failure to thrive or not gaining weight as a criteria for transplant, but in Alagille, we should not be taking that criteria. So another case, this is 1.5-year-old child, refer in view of hepatomegaly, and she was suffering from dry skin, rash and itching since 7 months of age. So look at this child, continuously cranky with the skin lesions, and she was treated like a atopy followed by eczema, and she was on multiple topical steroids with the multiple combinations, and the drugs like cetirizine, Atarax, everything was given to this child. So if I can have a video, she was continuously crying. And mind you, the family, the mother and father, has not slept more than 2 hours in last 7 months. So this was the severity of the itching in this child. So in investigation, the bilirubin was mildly raised, 1.5 with the direct fraction of 1, SGOT, SGPT mildly raised. The GGT is 41, PTINR normal, hemogram normal, lipid profile normal. So this is the different presentation of infantile cholestasis. So when I say infantile cholestasis, that means you should be remembering at least 3 different presentation. One is the first presentation, failure to thrive with the jaundice or a cholestatic like a direct jaundice. Second is the itching. It's very important to know itching as the presentation of infantile cholestasis. We did again the whole exon sequence, and that showed ABCB11, that is a type 2 PFIC, and the child has started on vitamin EDK, and for the itching or the pruritus, the same medications, rifampicin, ursodeoxycholic acid, ondansetron, cholestyramine. So the combination has to be given for the treatment. The beautiful part of this disease is that this disease, if the itching is intractable or the disease is progressing, you do the biliary divergence surgeries, and with the biliary divergence surgeries, you can have a good control on the itching, and the liver part, the liver progression also gets halted. So you don't have to go for the transplant for each and every case. This is another case, 3-month-old child, history of abdominal distension since 1 month, poor feeding, and no other significant history. The growth-wise, the weight was faltering, and this was the child. Huge hepatomegaly and splenomegaly. The liver function test, I will just go through it so that you understand that 4.6 with direct fraction of 2.1, SGOT, SGPT 200, proteins were okay, GGT 175, PTNR 1.9, the ultrasound was normal. But what clinched the diagnosis in this case was simple visual inspection of the blood. So this child had a milky white plasma. Liver biopsy showed fat, and as you rightly guessed, this is the lipid disorder. So the cholesterol 630, triglyceride was 6,600, and the parents were also showing the higher range of triglyceride and cholesterol. So this was the disease, fatty liver due to familial hyperchylomicronemia, probably due to the LPL deficiency. Started on MCT based diet and vitamin A decay, and he is doing good. So he's not requiring anything else than other than modification of the diet. So this is the treatable disorder, and now the cholesterol and triglyceride is in the 500. Another case, this is 1.5-year-old boy, abdominal distension for 7 to 8 months. The weight was and height was on the lower side. Hepatomegaly was there, a soft hepatomegaly. And this was the child, no other abnormality. The bilirubin and everything was normal, but I took because they are the hepatomegaly patient coming to you. CPK and even the lipid profile was normal. My differential diagnosis was at that time was glycogen storage disease. We did the liver biopsy and which showed the fat in the liver. It was a fatty liver. Though the lipid profile was normal, we sent the clinical exon sequence to know what is the disease the child is having, and this was the hypertriglyceridemia transient infantile type. So only for few years the patient will be having hypertriglyceridemia and fatty liver. You correct the diet for few months, and the child will not have the damage to the liver, and they will have a normal lifespan without having any difficulties. If you don't treat hypertriglyceridemia in the infantile age group, they will have a damage to the liver. If the damage leads to the fibrosis, and once the fibrosis sets in, it is the vicious cycle and the child lands up in the liver cirrhosis. So the take-home message that all hepatomegaly are not glycogen storage disorders, liver biopsy helps, and what really differentiate in the management or the investigations of infantile cholestasis nowadays is the clinical genetic tests which are available. So to summarize, for the infantile cholestasis syndrome, there is no clear-cut definition because the presentation is varied. Like first child has a cholestasis, the second child had a itching as a predominant presentation, the third child had a hepatosplenomegaly, the fourth child had an infantile cholestasis like presentation, but turned out to be a lipid profile disorder. I have not included the liver failure part because the liver failure part is really simple. It's infantile liver failure. You have the very few differential diagnoses like galactosemia, tyrosinemia, mitochondrial disorder, or urea cycle defect. So genetic testing has revolutionized the approach because as we are discussing that if I say a systematic approach to the child, 1 test, 2 tests, 3 tests, 4 tests, over a period of 1 month, the child will get lost in the follow-up. So what we really require is the 1 or 2 tests which will tell me the definite diagnosis, and that test nowadays is the clinical exon sequence, and which has revolutionized, which really gives us the final diagnosis. Thank you.